Hi, everyone. Welcome to Pathology of Disorders of Colon, part two. In this part, we're going to talk about colitis. So colitis comes from the word colon. It's combining form of colon in itis. Colon is, as you know, it's colon, and itis means inflammation. So basically, you're dealing with inflammation of colon. Patients present with symptoms such as abdominal pain, diarrhea, urgency, hemorrhage, incontinence. Diagnosis, you can diagnose this by laboratory tests. They do CBC, electrolytes, stool culture. They do ovoparasites to see if any mm, infectious etiologies are in the stool, CRP, calprotectin, and a lot of other laboratory tests. Then sometimes they do imaging on patients, and the mainstay of diagnosis is basically a colonoscopy and biopsy. There are different types of colitis, different etiologic consideration. You can get infectious colitis, immune-related colitis, such as inflammatory bowel disease, vascular-related, treatment-related, and also microscopic colitis. So we're going to go over the main types of colitis. The first one is infectious colitis. We're going to go over the pathology of it. So infectious colitis, basically the pattern of inflammation in the colon depends on the causative agents. In infectious colitis, most commonly you see active inflammation. You see acute inflammation. You see cryptitis. So cryptitis means whenever you have neutrophils in the epithelium, you have neutrophils in between the epithelium, or Greek abscesses. You have neutrophils inside the crypts. And also remember, whenever we use the word active inflammation in the colon, we mean there is acute inflammation, there's active injury, acute inflammation there. So this is a case of, acute colitis. Basically, so you have cryptitis, that your neutrophils are in between epithelial cells. And also you have crypt abscesses. The neutrophils are inside the crypts. As you can see, it's inflamed colon. This is a normal colon on the left side. For your comparison, normal colon is tube in a rax. There's no neutrophils there. There shouldn't be any inflammation. The inflammatory cells is mainly in the lamina propria, so you can have plasma cells and eosinophils there. Another example of colitis is pseudomembrane colitis. Basically, any colitis that's associated with pseudomembrane formation. So pseudomembranes, they are necrotic epithelial cells, acute inflammatory cells, and fibrinous material on the surface. This is how it looks like, a creamy yellow pseudomembrane formation. What can cause pseudomembrane colitis is Clostridium difficile colitis is the most common, ischemic colitis, inflammatory bowel disease. So whenever you administer any antibiotics, you can have overgrowth of the C. diff, C. difficile or Clostridium difficile, bacteria that produce toxins. They cause epithelial and endothelial damage and inflammation and cause pseudomembrane formation. This is how it looks like under the microscope. You have colonic mucosa on the base, and you have the pseudomembrane formation on the top. Pseudomembrane is necrotic epithelium, acute inflammation, inflammatory cells, fibrinous material. And in the base, you can see the crypts are distended, they're bigger and with mucin and neutrophils, and there are loss of the epithelial lining. These are the more normal crypts on the left, and the mucin is sloughing off on the right. Moving to inflammatory bowel disease. As you know, inflammatory bowel disease constitutes of two main diseases, ulcerative colitis and Crohn's disease. Ulcerative colitis, as you know, is a continuous involvement from the rectum and goes upward to, can entirely involve colon. Sometimes it can have a backsplash ileitis in the small bowel, but oftentimes it doesn't involve the small bowel. Crohn's disease, on the other hand, has discontinuous disease. It involves some areas can involve anus, oftentimes spare the rectum, but it can involve different areas. As you can see here, I have a bigger box here because it's mostly involved the terminal ileum and small bowel, but it can involve anywhere from mouth to anus. Whenever you look at depth of inflammation in ulcerative colitis versus Crohn's disease, in ulcerative colitis, if you have, this is the thickness of the wall. The wall, this is a lumen of the GI tract. You have mucosa. This is muscularis mucosa. So here to here is mucosa. You have submucosa, and this is the muscularis propria and serosa. So in ulcerative colitis, it only involves the mucosa layer. In Crohn's disease, it involves the full thickness. Not only you see active inflammation or acute inflammation, in inflammatory bowel disease, you see chronic inflammation or chronicity. So you see chronic inflammation, you see too many lymphocyte and plasma cells in the lamina propria, and also you see evidence of chronicity, and that would means that you have distorted crypt architecture. It means the inflammation was going there for a longer period of time, and now architecturally the colonic crypts are distorted. So this is a normal, colon which looks like tube in a racks. Whenever they are distorted, you will have different shapes of the crypts, and their crypts are going bifurcation like this. They're going sideways. They're making different shapes. These are evidence of chronicity. You also have active inflammation, as we spoke about, like acute inflammation. You can have cryptitis, or you can have crypt abscesses. In Crohn's disease, the difference with UC and also the colitis, inflammation is limited to the mucosa. In Crohn's disease, you have transmural inflammation throughout the wall, and you also can have non-caseating granulomas. But again, remember, not all cases have granulomas. This is an example of ulcerative colitis. As you see, the inflammation is limited to the mucosa. And, the submucosa in the deep down, there's not much. There's a little bit lymphoid aggregate here, but other than that, there's no acute inflammation. There's nothing in your submucosa. This is normal colon on the bottom right for comparison. You see the crypts are same distance from each other. They look like tubes in a rack. They're just sitting on your muscularis mucosae, very normal looking. Here in ulcerative colitis, you can see crypts are going sideways. They are branching like that. They are forming different shape. There is acute inflammation. You have crypt abscesses. The inflammation is inside the crypts. You have cryptitis if you look around. And also you have, inflammation expanding your lamina propria. Expanding the lamina propria. So it doesn't look normal anymore. In Crohn's disease, you see inflammation involving the transmural inflammation, not only in the mucosa, but also in your soft mucosa and also in the muscularis propria deep down. So this is the remnant of, the transmural inflammation. On surface, you see focality of inflammation. Some areas looks normal, still looks like tubes in a rack. Some areas look abnormal and very inflamed. The area of abnormality, you can have granuloma formation. Not all cases we have granuloma. You can have the active inflammation, like crypt architectural distortion, as we talk about, but it's very focal. Moving to another type of colitis, which is microscopic colitis. Basically, patients present with chronic non-bloody diarrhea. There are two entities in microscopic colitis, either lymphocytic colitis or collagenous colitis. The radiologic and endoscopic studies in microscopic colitis are normal. Pathology can identify the process. Mainly, they biopsy these patients that are normal looking on endoscopy, and they want us to rule out microscopic colitis. So this is how a normal colonic biopsy looks like. There's not much inflammation. There is very sparse, lymphoplasm cells in the lamina propria. Crypts are like tubes in a rack, same distance from each other. Whenever you have lymphocytic colitis, the architecture is still normal. The tubes, all the crypts are same distance from each other. They're not distorted, but they're very busy. They have a lot of lymphocytes in between epithelium. As you can see here, it's not busy looking. It's not purple looking. There's not many lymphocytes here, but here there are tons of lymphocytes in between. There's somewhat surface injury, but mainly you have lymphocytes, a lot of lymphocytes in between epithelium. Another type is collagenous colitis. In collagenous colitis, you have collagen deposition in the subepithelial region. So you have collagen deposition under the surface. The surface epithelium does not like this collagen deposition underneath, so it gets sloughed off. As you can see, the surface epithelium is sloughing off. And if you have any question if this is collagen or not, you can stain it with, trichrome or Masson stain, which is this stain. It's just like the collagen will be blue. And it highlight the collagen deposition. And also this collagen will entrap blood vessels, and you can also see some intervals. So in summary, colitis is basically its inflammation of colon. Colitis can be a result of a lot of etiologies, can be a result of infection, it can be a result of immune-related like inflammatory bowel disease, treatment-associated medication, diverticular disease can cause inflammation, microscopic colitis, and so on. So in order to rule out these, you have to have like laboratory tests and endoscopy and biopsy. Patients that are on antibiotics are at risk for pseudomembranous colitis, oftentimes, caused by Clostridium difficile. And this is the end of it. Thank you for your attention, and